Welcome to AETCM, the Emergency Medicine channel. Today we are presenting a case of 49-year-old male presented to ER with complaints of low backache for the past 1 day, which was aggravated on walking and sitting. On initial 10-second assessment, airway was patent, no pooling of secretion, breathing was 16 breaths per minute, saturation was 100% room air entry bilateral equal. Coming to circulation, BP was 150/90 millimeters of mercury, pulse rate was 96 per minute, bilateral pupils, bilaterally peripheral pulses are equally felt. Coming to GCS, disability, GCS was 15/15, pupils equal and reacting to light, exposure, patient was afebrile and he was having a pain score of 8/10. So after ruling out any an allergic history, we have given injection ketorolac 1 ambule IM stat and the pain score reduced to 6/10. Coming to history, a 49-year-old male who is a known case of hypertension presented to ER with complaints of low back pain for the past 1 day. It was aggravated on walking and sitting for a long duration. Pain was radiating to the right lower limb and which was relieved on rest. There was no bowel or bladder symptoms. Past history, the patient is a known case of hypertension on telmisartan.
Okay.
So on coming to clinical examination, general examination, patient was conscious oriented, no pallor, rectus cyanosis, clubbing, lymphadenopathy. Local examination on spine inspection, there were no external injuries, no gross deformities were inspected. On palpation, there was no local warmth or no spinal tenderness, no palpable deformities.
Okay.
And distal pulses were felt, sensations were equal, SLRT was positive over the right side.
Okay.
And then at 30 degrees. And there is the muscle weakness, there was only the extensor hallucis longus of the right foot, that is the dorsiflexion of the great toe was having a weakness.
Okay.
All other, there were no other muscle weaknesses. And other systemic examination was normal.
Okay.
So we directly proceeded with MRI, with LS spine, and it was showing a disc bulge of L5S1 level predominantly at the right foraminal and extraforaminal region, causing mild narrowing of neural foramina and compression of exiting nerve roots. So we had given an ortho consultation, they admitted the patient and it was conservatively managed.
Okay. So one of the most common presentation to the emergency room is low backache. So you can have different sets of patients coming in. So how can you classify low backache coming to the emergency room? What is the most common one? What is the most common presentation of patients coming to the emergency room? The most common is non-specific mechanical pain. So that is the most common thing that they will be presenting into the emergency room. So that is the first set of patient. So in the next set of patient, what we see is the, like what we have seen is the sciatica. So that is the second group of patient. And third set of patient, it can be a group of patients together. We can call it as some emergent pathologies underlying to the patient, they can present with back pain. So these are the three sets of patients. The top one be the most common presentation, the mechanical back pain, because they will be doing some not ergonomically sitting in their office room. They are coming with a low backache. Maybe they would have lifted something. Suddenly they have come with some muscle spasm. So this all will come under that category. And the next category is the next will be the sciatica. And third one will be the emergent pathology. So under emergent pathologies, we should not miss those group of patients. So what are the common pathologies that you need to suspect when somebody is coming with back pain? One.
Medical causes like pancreatitis.
Instead of medical causes, let's see the spinal issues. What are the spinal problems that you can have?
Any disc bulges?
The most common fracture dislocations. You can think that pathology, a fracture or a dislocation of the spine. Then you can call, rather than calling it disc bulge, you will call it as a cauda equina syndrome. So sciatica, cauda equina syndrome, there will be certain differences when bladder involvement is there and there is saddle anesthesia, we can call it as cauda equina syndrome. The next pathology will be a malignancy presenting with the back pain. Then we have the infections. Infections among the most common one, it can be a pot spine and osteomyelitis or an epidural abscess. The IV drug abusers, they are coming you with a back pain. You have to think of an epidural abscess. Then the most common one will be psoas abscess. Then discitis, osteomyelitis, discitis, all the infection pathology. Then one most important thing that we should never miss, especially for an elderly age group coming with back pain, Elderly age group coming with back pain.
Angular spondylosis.
Okay, elderly male above 60 coming with a non-specific back pain, abdominal aortic aneurysm. So abdominal aortic aneurysm. So these are the most common one, and ureteric colic, that will be not in the center, it will be more in the loin region. So these are the emergent pathologies that we need to focus upon. So our idea will be to differentiate between three sets of patients. So which patient needs evaluation and what are the different types of investigation that needed depends upon what all the things are there. So for that reason, we always have a red flags for back pain. So what are the common red flags as an emergency physician you should know from the history, what all things you should be looking into?
First one is radiculopathy, that radiating to the lower back pain like sciatica. Then any focal neurological deficits, and and regarding the other causes, any hypotension, syncope,
Fever, extremes of age, previous history of malignancy, age less than 18, above 60 malignancy group, then who's on a drug abuse, IV drug uses, trauma history. So these are all red flags that we need to consider. So whenever you have any set group of these patients, bowel and bladder involvement, you said neurological deficit, include the bowel and bladder involvement, that should keep in your mind. These are the common red flags. So we have a set of patient, any patient that has come with, we have seen that, okay, there are no red flags, and the next important thing is the starting off with your examination. And the most important examination that what you do, you have to do a proper spinal examination. And the important investigation that we all do for a low backache patient is a straight leg rising test. So how will you interrupt a straight leg rising test?
Patient should be supine position. The straight line leg raising test is a passive test. We have to hold the ankle of the patient, and then we have the examiner have to raise the test, raise the leg, and from 30 to 70 degree, if the patient is having this pain, low backache, radiating, it is positive straight.
What will be the most striking feature of a straight leg rise? Contralateral pain. So that is the most striking thing. Not in the affected side, not from the lifting side. If the patient is complaining of a contralateral, that will be more striking of a straight leg rising test. So you have to understand that what will happen when you are rising, when there is a small discus that can cause and protrude and cause much more worsening of the symptoms. So that is the most important investigation that you need to look for. And definitely we have set the red flags. Depending upon that, you have to look for the spinal tenderness, bowel and bladder involvement. Sexual dysfunction history is very, very important. So somebody is coming with, you have to ask for this history. So these will be they will not be, unless you ask, you will not be able to get. And bladder involvement, when we say regarding back pain with bladder involvement, what will be the, when you have cauda equina syndrome, and we have different bladder involvement can happen. So cauda equina syndrome, what will be the problem that you can happen to the bladder?
Urinary incontinence and overflow.
You may have significant post-voidal residue. So that is a role when you have to look for an ultrasound. So you have to look for significant PVR. So when you have cauda equina syndrome, ultrasound in back pain, two indications: to look for your abdominal aortic aneurysm and to check for post-voidal residue. So these are the two major indications for an ultrasound. So that is the next thing. So again, IV drug users, then epidural hematomas. Epidural hematoma, which group of patient you will suspect? Epidural hematoma, again, it will be a spontaneous in onset. There might not be any trauma history. So epidural hematoma, the patient is coming with back pain and you have suspecting an epidural hematoma. When will you suspect? Patient on anticoagulants, pretty simple. Anticoagulants. And another group of patient I have seen couple of patients, those who are on hemodialysis, because they will be getting heparin in between dialysis and they come with low backache. Because you need to recognize this epidural hematoma. So that is the one group of patient on oral anticoagulants. They are coming with a low backache. You have to think, are we dealing with an epidural hematoma? So back pain, the most chunk of the patients are quite stable. These are all mechanical back pain. And there is something called as yellow flags. Have you heard about something called as yellow flags? Yellow flags, when you are assessing the patient is having a lot of doubt in his mind. It might be a mechanical back pain. So whether he should be moving around, he thinks that he should be taking more and more rest rather than being more and more active. He thinks that he should be taking rest more so that his pain will be relieved, and he has got a lot of anxiety inside his mind. So that is categorized as yellow flags for back pain. So the mechanical group of back pain, they can have yellow flags also. So these things you need to differentiate, and they need aggressive physical medical rehabilitation rather than being on the bed. So the wrong concept, what the people think in their mind, when they have back pain, mechanical back pain, they should be more active, then only their pain will subside. But in other cases it's different. But when you have a mechanical back pain, they should be taking more and more physiotherapy. Now coming to the next, you have done the evaluation, investigation per se. Let's start with the radiological investigations. So we have modality X-ray, CT and MRI. So we have this three modality. So when a patient comes to the emergency room, they will be thinking that you're telling nothing is there. Without an X-ray, they won't be happy. So really when an X-ray is indicated? When you suspect a fracture, it's simple and straightforward. When you suspect a fracture, when you have a bony tenderness, only an X-ray is warranted. Otherwise, there is no role for an X-ray for any of this mechanical back pain that is coming to the emergency room. So that is not needed. What you will be able to see in that X-ray? Just the straightening. The normal lordosis will be lost, and there will be spinal straightening. That is the only thing. And again, one of the important red flag that we miss, thoracic pain. Thoracic, the patient is complaining of thoracic pain, that is also very, very significant. Usually you don't get thoracic pain. So thoracic pain, when somebody is complaining, that is mostly a malignancy related pain. Thoracic pain is not very common. Now another important history, that again red flag that you need to keep in your mind, is that pain not even subsiding while lying down. Even the patient is lying down flat on the bed, unable to sleep because of the pain. Again, malignancy related pain you need to consider. And another differentiating features between a disc involvement and a spondyloarthritis, when we discuss, when the patient is pain is more towards flexion, it will be more to the disc involvement, and to extension, it will be more due to the spondyloarthritis of the joint. So these are the simple tricks that we can able to differentiate between what is the basic pathophysiology that is happening to the patient. Coming to the investigation modality, X-ray we said. Next to the CT. So when we ask for a CT,
if there is fracture,
again fracture, we can ask for a CT. But important thing, the gold standard investigation when you want to really evaluate is an MRI. So MRI spine is the gold standard evaluation, and again CT with CT angiogram or CT iotogram also might be required when you are suspecting a AAA. And ultrasound, as I told you, two conditions that you need to keep in your mind. One is your to look for post-voidal residue, and to look for the abdominal aortic aneurysm. So these are the radiological evaluation, and other investigation per se as such. What all things you need to do, markers, your infective parameters to look for all calcium level. When you are suspecting a hypercalcemia, back pain, malignancy, all those things will come into the picture. Now, we have to differentiate between each one of these pathology. So first, let's see cauda equina syndrome. So what will be the presentation of a cauda equina syndrome?
Low backache with bowel bladder involvement.
Okay.
Focal neurological deficits will be there.
Okay. And saddle anesthesia. Don't ever forget, it's a saddle anesthesia. That will be the classical of the cauda equina syndrome. And the next one, spinal metastasis.
Spinal metastasis, bone pain with more during
significant tenderness and lytic lesion in the X-ray or CT. So that is the differentiating features. Epidural hematoma, we have to take an MRI. Without that, we will not be able to come to a conclusion. Sciatica, yes, MRI is again the gold standard investigation. What you need to differentiate between these things. Now, coming to the management per se. So management aspects, 1, 2, 3. First, the mechanical back pain. So what will be the advice for the mechanical group of patients?
analgesics and adequate movements.
Active movements. They should be more active. They should be more active, and you should be seeing what is the reason behind the back pain, and that can be done by an physical rehabilitation team, and you can send them to that. The next group of patient, sciatica. What happened to this patient?
Sciatica, if there is disc bulge, we can laminectomy, discectomy can be done.
Or else, as an immediate measure, you can even give 1 dose of steroid. If there is a significant cord edema, everything is there, that steroid can help. Dexamethasone is the gold standard, can be the best treatment option for that group of patients. Next one, coming to the cauda equina syndrome.
Cauda equina, mainly the compression thing.
Is there? You have to relieve the compression. So you have to go ahead with the laminectomy only. Coming to spectral metastasis, you have to look for where the metastasis is there. Maybe you need fixation of the spine. Otherwise, the patient will go into further weaknesses and all. And third one, you have the epidural hematoma. The drainage of abscess is the most important one. And finally, what else we have missed? AAA, that is abdominal aortic aneurysm. Definitely surgery is the gold standard. So what has been done to this patient?
He was on conservative management, that is on analgesics and active movements, and it was relieved also.
Okay. So as an emergency physician, a low back pain, when they come to us, our aim should be to understand which group of patient we can safely discharge. which we need further evaluation. Everyone doesn't need an evaluation with an MRI or an X-ray. So whom need to be admitted, whom need to be discharged, and what are the basic difference features that you need to keep in your mind. That is our role. Okay. Anything else that you have to add?
Mainly that the motor weakness reflexes examination for L4, L5.
Yeah, that you can tell.
For L4, the numbness will be the medial thigh and the knee, and the motor weakness will be extension of the quadriceps, and the examination will be the squat and rise test, and the reflex will be knee jerk, that is diminished.
Okay.
L5. And for L5, numbness will be the lateral leg, motor weakness will be the dorsiflexion of the great toe, that is extensor hallucis longus, and examination will be heel walking, and reflex is non-reliable. For S1, the numbness will be the calf and lateral foot up to the last digit. Motor weakness will be plantar flexion of the great toe and the foot. Screening examination, walking on toes, and ankle jerk will be the reflex to be seen. So patella is L3, L4, and ankle dorsiflexion is L4, great toe means extensor hallucis longus is L5, plantar flexion is S1, S2, and Achilles, that is ankle jerk is S1.
Okay. So just keep these three differentials in your mind always. So we should not miss the emergent pathology. So that part we need to keep in your mind. And the worst thing is an abdominal aortic aneurysm that we are missing in. So that is going to be a deadly, life-threatening condition that if we are missing that. Okay. Thank you.